there really isn't a better time to be talking about this, the changing map, global health on shifting sands. Because I don't think 6, 7, 8 months has ever seen such an absolutely astonishing change in global understanding and norms and standards. So what I'm going to be really thinking about and talking to you about and hopefully having a discussion is that this is what we're facing: volatile politics, new nationalist priorities, and slashed global health funding. And everything is challenged, nothing is normal. What is the role of WHO and the global funding agencies? What is the role of countries and their contributions? What about Southern leadership? So part of the question and part of the reason for having this is that we start to think. So I framed this talk. The first half is giving you the reality news. The second half is going to say to all of us here and online, what do we do next? How do we actually tackle this? So this is a sort of a way of looking at what I'm going to talk about. I'm going to cover global governance and the global health architecture, and then look at misinformation, disinformation, and trust in science and where we are. And then look at health research and emerging technologies. So let me start by looking at global governance and the global health architecture. So I'm starting right back at the beginning with the start of WHO. And in the end of the 19th century, there were early what were called sanitary conferences, mostly because of cholera outbreaks. But after World War I, we had the first global organization, the League of Nations Health Organization. And after World War II, this is when WHO was founded. The UN Charter included a health mandate. WHO was founded, and in 1948, the first World Health Assembly of countries was held. And in 1946, just look at this definition of health. This is what WHO said: health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. And that was 1946. So how did global health evolve? Well, tropical medicine was probably the founder, and this was in the late 19th, early 20th century. And the motivation for this primarily, I think, came from the UK, because they were worried about the colonial countries and people living in the UK becoming infected with things like yellow fever. From there, LSHTM, which I'm fortunate to be an honorary fellow, the London School of Hygiene and Tropical Medicine. And so it's called hygiene still. And they've hung on to that name, but of course we all know it as LSHTM, but it probably is one of the biggest players in global health today. And that was founded to really address some of these issues. International health then evolved between the 1940s and the 1970s, and the philosophy was that rich countries can help poorer ones, and in the same period WHO was established. Globalization really emerged then in the 80s and 90s, and this was because of international travel and the emergence of the HIV pandemic. In the 1990s to 2000s, we started to see academic institutions, mostly in high-income countries, talking about global health. And then global funding institutions such as Gavi were founded. But now we've got to the point, 2010 onwards, with many definitions that global health is a global public good. And it's really attached to things like climate change and pandemics. And I'm going to just go back, and I'm going to give you some people's, for me, sort of sentinel thinking over a bit of time about what primary healthcare and what healthcare is about. And this is Julian Tudor-Hart. Some of you might not have heard of him. He was a GP in a Welsh mining village called Glencorrwg, and I did my student elective with him, but he was a real future thinker, and he did research. He did research on colon cancer and various other things. But one of the things that he said in some of his publications was this: medical services are not the main determinants of morbidity and mortality, but because these depend on nutrition, housing, the working environment, and education. And interestingly, then in 1971, he said the presence or absence of war. He published this paper in 1971 called the Inverse Care Law. And in the Inverse Care Law, he argued that the availability of good medical care tends to vary inversely with the need for it in the population it serves. If you look at the graph on the right, on the y-axis, the resource input per capita goes down according to need. So you end up with an unmet need. That's to say, the bigger your need, very likely, the less resources you get. So the inverse care law argues that socially disadvantaged populations receive less health care than socially advantaged populations. Moving on, there was then a whole plethora of documents that talked about the social determinants of health. And in the Lalonde report in Canada in 1974, it said again, we must go beyond healthcare services. And they actually included, at this point, lifestyle and the environment. That was the first time the environment had really been noted. And then David Saunders, who has sadly passed away, who was an incredible public health academic. He worked at the University of the Western Cape, but he worked extensively in Zimbabwe after its liberation. He wrote the book, The Struggle for Health, in which he introduced social determinants of health and issues of social justice. And then a very famous researcher, Richard Marmot, in 1999, published many things, including a book called The Social Determinants of Health, where he talked about social, political, and economic factors shaping health and health disparities. We move on to 1978. Now comes primary health care, the Alma Ata Declaration. And importantly, this is one of the things, I'm not going into what primary healthcare says, it's the first point of delivery and it promotes health promotion. But look at what it says in the declaration. The existing gross inequality in people's health status is politically, socially, and economically unacceptable. Economic and social development is of basic importance to the reduction in the health status gap between developing and developed countries and contributes to a better quality of life and to world peace. And I'm just emphasizing that because that's what Julian Tudor Hart also said. It contributes to wars and stopping wars. But the idea of primary healthcare was core as a core pillar to our thinking in the post-apartheid health system. And then came in 2015 the Sustainable Development Goals and universal health coverage. And additional thinking was put into what we need to do, particularly the Sustainable Development Goal number 3. Here we started to talk about equity in access, financial protection of people when they get sick, affordable medicines, health system strengthening, human rights and social justice once more, but also the economic benefits of healthy populations. And one more that I'm going to mention, this is not a WHO or a UN declaration, but it is a group of 70 countries with WHO and UN agencies and civil society. And they have developed what's called a global health security framework. And the reason they developed this, if you look at the table on the right-hand side, is that we're seeing more and more outbreaks. You can see that in the African region, that black bar at the top, we have seen an increase in outbreaks in the last 10 years, certainly, and more frequently in the last since with COVID and past that. So 26 countries in this region have got increased numbers of outbreaks, and only 8 have got decreased. And this global health security framework aims at combating zoonotic and emerging diseases such as Ebola, antimicrobial resistance, which is in the top 10 threats according to WHO, preventing bioterrorism risks, and promotes the importance of strengthening national core capacities to respond to emergencies. Now, if you put those two things together and remember the inverse care law, just have a look at this graph. It's a scatter plot, and it shows a universal care index, which is a measure of 14 measures of how are your health services doing, and then the Global Health Security Index. And what you can see in the scatter graph of 183 countries as you go down is that the lower your Global Health Security Index is, the lower is your capacity for universal health coverage and vice versa. So you remember what was said, the countries that need it and the people that need it most get the least resources. This shows you global health security and universal health care are both together at the bottom. And the other thing that has really come and is pushing the thinking around global health is what happened in COVID. Remember, access came up in universal health coverage, and those definitions, access was the word that came. But in COVID-19, what did we see? We saw that we were hugely delayed in getting access to vaccines in the African region. While we could not get access in some countries for months after they were needed, they were stockpiling in high-income countries. And this really shouted to the world that we have an inequity problem between rich and poor, developed and developing countries. The African Union, the leadership, woke up and said, whoa, hold on, we're manufacturing less than 1% of the vaccine doses we need of anything in this continent, and we need to actually correct that. As a result of all of this, two things happened, and Precious will talk to one of them later as well. The international health regulations have been in place, in fact, since 1969, and interestingly, there are not many legal agreements that WHO has, but they have the international health regulations. But they were put in place to respond to emergencies and outbreaks. But after the SARS outbreak in 2002, they were revised because they clearly were not fit for purpose. And what the international health regulations do as a legally binding document, they create definitions and rules for countries to prevent, detect, respond to, control, and communicate on what are called public health emergencies of international concern, FAKE. It's a bad pronunciation, FAKE, but they're real. And there haven't been very many of them, and the only one that's ongoing at the moment is for polio. A FAKE is defined as an extraordinary event, as determined in this document, and it constitutes a public health risk to other states through international spread, and it will benefit from a coordinated international response. Those three things will define a FAKE, and clearly COVID-19 was such a thing. Apart from polio, Mpox recently has also been a global and international FAKE. But since then, we've also had Ebola outbreaks and the COVID-19 pandemic, and this exposed once again serious weaknesses in this document. So this document, the International Health Regulations, has now been revised, and it was improved by the World Health Assembly of WHO in 2025. But the other thing that also COVID woke everyone up to, in terms of access, equity, fairness, and how we respond to pandemics, was that we do need a global pandemic agreement. And from the last 3 years, a committee has worked on that. That is the committee underneath there. And this is the lady who's standing in the middle of this committee, Dr. Precious Matsotso, who was the co-chair of this committee. And the pandemic agreement was approved by the World Health Assembly in 2025, but with lots of residual unanswered questions. So it still needs to be ratified next year. Some of the questions are financing, logistics, One Health integration. This is, how do we do surveillance in humans and animals for these zoonotic diseases that are jumping? Many of the African countries are saying, listen, we haven't even got money to do surveillance in humans. Now you're asking us to do animals as well. The accountability and legal framework needs to be thought out, and pathogen access and benefit sharing, and I'll explain that to you. But the US has not signed up because, unfortunately, as you know, they have left the World Health Organization. So PABS is the pathogen access and benefit sharing. What that is about is access to health products in an emergency. And the idea of this is that when you have a pathogen, if you can share it globally, then scientists around the world can have a look at the characteristics of the pathogen, can look at its genomics, and can develop vaccines, therapeutics, diagnostics. That's the idea, and that is what is thought is essential for a pandemic. But the problem is, it's all very well, but if Africa ends up not getting any of the products, we might well share the pathogen from here. That is inequity. And so one of the comments from the African contingency on this committee is that during a pandemic, they would like to see that manufacturers provide WHO with 20% of real-time production of vaccines, therapeutics, diagnostics, 10% free and 10% at affordable prices. So that's the background to sort of where global health has got to in one perspective. But we also have a whole lot of global health commitments. So how are we doing on those? Well, first of all, we have a climate change convention. COP29, which occurred this year, has clearly said that we're off track. And if you look at the graph below in the orange, we exceeded that 1.5 degree warming, which is what we were trying to avoid. And the climate scientists are saying we can forget that. If you look on the right, the blue shows the frequency of heat waves that are occurring in the United States. And you can see they're going up. And the orange shows that the average length of heat waves. So the heat waves are more and they are longer. And irrespective of the fact we know heat is bad for people, even heat waves which have a limited time are also bad in terms of cardiovascular disease, respiratory disease, and mental health. Another treaty, the Plastic Pollution Treaty, also off track. There was a big meeting in August of this year, and unfortunately there was no resolution. Plastics, microplastics are in our water, they're in the air, they're in our food, and they also have significant impact on our neurological systems, respiratory, digestive, reproductive. So these are also a health threat, off track. What about air pollution? Well, we don't have a treaty that's being looked at, but there are many guidelines on air pollution from the World Health Organization and in the SDGs, the Sustainable Development Goals. How are we doing? Well, indoor and outdoor air pollution is increasing in some areas. It causes about 8 million deaths globally every year. And while there's been improvement in Europe, North America, and China, areas like regions like India, parts of our continent here, and Central Asia are getting worse. And in fact, if you look at the Gini index, which is a measure of inequality, the Gini index for air quality between 2000 and 2020 actually widened, saying that poorer countries are suffering more. And you can see there again that, as you would expect, this is going to have an impact on respiratory, but also things like cardiovascular disease. And the latest research is also linking air pollution with dementia. Very little is said about slums, but there are lots of agreements on slums and housing. And the UN Habitats for the New Urban Agenda framework to upgrade slums exists, as does an SDG for housing. And both of them talk about the need for adequate, safe, affordable housing and basic services to upgrade slums. But as we're sitting here today, over 1 billion people worldwide are living in slums, and urban slums are increasing. Slums are characterized, as you can see in the photo, by sewage, garbage, poorly constructed homes, air pollution, and physical hazards. And the risk of communicable and non-communicable diseases increases if you live in slums. And if you look at the bar chart on the right, in sub-Saharan Africa, right at the top, between 2020 and 2022, the number of people living in urban slums has increased to 53.6% of people living in urban areas. And if you think that that picture below is some slum somewhere far away, it's not. It's the Florence building opposite the Concourt for those of you in Joburg. That's what it looks like. No water, no sewage, no electricity. Fires have burnt to death children in there. And this is what the center of it looks like. This is Joburg. And so in the environment, two more things where we have got agreements. Antimicrobial resistance is also, as I say, in the top 10 concerns worldwide. There are guidelines, both from the UN, from WHO, but importantly, United Nations has discussed this, which is unusual. They don't usually put things like health onto the agenda. 31% of the 40 most used antibiotics worldwide make their way into rivers. Nearly 5 million deaths every year are associated with this. And the highest burden, once again, is in low-resource settings. So if you look at the graph again, all those green bars on your right are those green bars are the African region. At the other end are the high-income countries where you're protected against death and illness from antimicrobial resistance. And the last one I'm going to talk about in terms of what we're doing and where are we on track or off track, sadly off track again, is non-communicable diseases. Again, there's a UN declaration on non-communicable diseases with targets and a WHO one, but no countries will achieve the 2025 targets. And it's a leading cause of premature death and disability worldwide, with over 17 million people dying of cardiovascular, non-communicable diseases in 2021. If you look at the graph on the right, you can see the leading causes in yellow, cardiovascular, red, cancers, blue at the bottom, diabetes, respiratory diseases in light green, and mental disease in the green above. So we're not on track there. So all a bit grim. 6 of them I've shown you, 6 we're not on track, and some of it we can put down to COVID, but some, unfortunately, we can put down to funding. And now this. So, reduction in official development assistance for health. So, how to start thinking about this? In 2024, this was the situation. Sub-Saharan Africa was the largest recipient of US health aid. You can see by far $42 million of overall for health aid. On the right-hand side, you can see that 70% of the global HIV/AIDS response was also contributed by the US. And that was hugely important for mother-to-child transmission and keeping people on treatment. Then on the other side, you can see that the US donations to the UN accounted for 40% of humanitarian aid. So putting all that together, what has just happened? This is what's just happened. Here you can see different countries with the US in yellow, and other countries. You can see Germany in green and other countries there, and philanthropists. But you can see that we had a huge peak in global aid during COVID, and suddenly in 2025, this astonishingly sudden slump. So what do we do about this? What do citizens of rich countries think they are giving? And I think that's very important, because this is obviously a very political issue. In the pie chart on the right-hand side, you can see that 1.3% of the US GDP, this was prior to the cuts, was going to international affairs, and that included diplomatic, economic, and foreign aid programs. 1.3%, including the foreign aid programs. Then you can see in the blue bar chart that for the UK, 0.5% of their total government spend went to aid. Then this is a number of studies that I found that were looking at people's belief around how much are their governments giving to aid. And you can see in the first bar, from the US, UK, and the EU, huge overestimations of what their governments are giving for international aid. US 25%, UK 10 to 15, EU on average, there were several studies, 10 to 20%. Whereas when they were actually doing these studies, this was the actual spend, 0.2, 0.5, 0.5, 0.6. But the spend is going to cut, and you can see what we think is going to happen. If the spend cuts are as might occur from the US, it could go down to 0.03%, but 0.3% in the UK by 2027 and 0.3% in the EU. So cuts are coming, cuts have come. This is a study that looked at what was the impact of USAID funding and what is the possible impact of the withdrawal. You can see that that USAID funding, or the US government funding rather, saved huge numbers, millions of lives. Over 90 million lives were saved between 2001 and 2021. In the people receiving that aid, the mortality for all ages went down by 15%, but also by nearly a third in the under 5-year-old age group. The disease-specific mortality for HIV down by 65%, that was thanks to PEPFAR, malaria 51%, and the list can go on. The modeling in this study suggested that between 25 and 2030, if we do see this huge cancellation of international aid by the US government, you can see how important they were. Then you would get potentially another 14 million deaths, additional deaths globally, and another 4.5 million deaths amongst children. What has the impact of these cuts been on the World Health Organization? I've just outlined how important it is. You can see that they've had about a fifth of their budget cut, and that means that they've slashed about 20% of their staff, both at HQ and in the regions. They've slashed staff and activities in their global programs. And they have many targets for eradication and elimination. The eradication target is for polio. Polio has had six times since 1988. The polio eradication program has said to the world, we're nearly there, and has set an eradication target date, but had to move it. And the difficulty with polio is you get that close to eradication, and as long as you've got a few infections, if you take your foot off the gas, that's what happens. And this is what's happening with polio. But now polio is really being affected because they too, as one of the WHO programs, have had a massive cut. And so they're looking at what do we do? They're once again going to have to change their eradication target. The African region has lost over 150 million from operations and programs very rapidly. US and Argentina have withdrawn from WHO. And RFK Jr. Has proposed in a talk that he gave at the Gavi replenishment meeting that there is a discussion going on for an alternative or accountable health institution, global health institution outside WHO. There's also been an impact on global financing institutions. I've just given 3 examples here. The World Bank is a major financer for low middle income countries for health. They give either grants or very low interest loans. Fortunately, at the moment, it looks as if their income is stable. But if you look at the pandemic fund, which was set up to have a fund for pandemic preparedness, they have a very low ability to raise funds at the moment. They depend on voluntary contributions. And there are real funding uncertainties there. But just put that side by side with what I've just also spoken to you about, the pandemic treaty. So on the one hand, we've agreed to a pandemic treaty. On the other hand, we can't fund a pandemic fund. And then we have the African Development Bank. And this is a regional bank which provides broader TA and development finance, again through grants and low-interest loans. But again, there are real funding uncertainties. So it's not only countries and programs and the World Health Organization, it's also those that loan and give grants. And what will happen if countries are stuck? If you look at the graph with the green, this looks at the foreign aid received as a share of national income. And over 50% in this study, which was a modeling study, it was estimated that over 50% of low-income countries are at high risk of a debt crisis. And if we look at the regions in the bar chart there, looking at servicing those big debts that countries have as a percentage of their spend by the regional groups, Africa, on average, is spending over 50% just servicing those loans. So it's all a bit grim on the finance side. But what about science, evidence, misinformation, and disinformation? Well, health policy has always been a bit political. That cartoon I'm sure many of you have seen before is what was seen about early smallpox vaccination with cows coming out of people's mouths. So it's always been controversial. But during COVID-19, preventive measures such as the use of vaccines and masks became reframed as partisan and political symbols. And what we learned from that is that political identity can strongly shape health behaviors. It can decide if leadership politically or culturally says don't use vaccines, it can strongly shape how populations respond. Polarization of public health measures has become more and more a risk factor for health. And here's an example of how that plays out. This is from RFK Jr., who has agreed with another statement that mRNA vaccines cause serious harm, including death, especially amongst young people. He also said that CDC officials failed in their responsibility miserably during COVID. On the other hand, you have Seth Berkley, the previous CEO of Gavi, which is a global alliance for vaccines and immunization. And in a recent article in Science, he said, ignoring scientific evidence, embracing anti-vaccine conspiracy theories as official government policy, cutting critical research, and abandoning global partnerships such as Gavi will ultimately make Americans less safe, which is not the intention of the current administration. So misinformation and disinformation, how have we got to this point? So just this is a Financial Times article. If you look on the right-hand side, traditional media was started with the printing press, newspapers, radio, TV, and they expanded access to information for the ordinary person. But the control of that information was in the hands of elites when it all started. Social media, on the other hand, opened content creation to many people, to everyone, amplifying diverse voices. And if you look at those graphs, at the estimated share of content in this particular study showed that traditional media tends to favor moderation. Cable TV, which has more of a bias, tends to have more of the extreme views, both right and left. But look at social media. Social media is the platform where anyone can speak, and this is where you're seeing a lot of the extreme views expressed. This was a study that was reported to have been done this year in 25 countries, where they said to people, what's your opinion about the biggest global threats? And interestingly, the number one came out was the spread of false information online, followed by global economy and terrorism, but it was actually false information online. So this is what we're dealing with. So therefore, here's a thought. We can't just sit here and ask for faster horses. We must now all think differently. So what I'm going to do now is just suggest some of the areas in which people are thinking differently and how we're going to tackle all of these problems I've just outlined. First of all, the global health governance and ecosystem, and many people would say it was bureaucratic, it was over-bloated, it needed to be re-looked at. And this is an opportunity to do it. So there's a huge discussion that's gone down about streamlining global health structures. Who does what best, who should lead, who's got the mandate, what is WHO's role, and who's going to fund it. But you can see in the box that there are many, many, many agencies, organizations, both civil society, professional, funders. There are many agencies that are involved in this. So this is going to take some time to unravel, but it's being looked at. WHO was forced to look at what they are doing, and they, because of course they had a huge funding cut of about a fifth. So they've cut immediately their leadership structures, they've redone their executive, they've halved their leadership. They've made emergency responses now their top priority, not one of many. And they want to devolve technical support to countries much more around country priorities and a regional focus. Data and surveillance, they want to do streamlined and faster. And for research and innovation, there's a recognition that they shouldn't be doing the research, but they should be working with partners to do that research. But what is seen as absolutely core to WHO's role are standards and guidelines and their normative role of making guidelines and recommendations incredibly important for countries in this region, and equity and advocacy. But there's a broader discussion beyond WHO that's really going on because of this feeling that we really needed to change, and the UN system needed to change, that it needed a bit of a shake-up anyway, even before what happened more recently. So at the moment, Gavi, the Global Alliance for Vaccines, and the Global Fund for HIV, TB, and Malaria are talking together to say, can we have operational efficiencies on the ground? Can we have strategic alignment? Can we work together much more closely and save money? The UN 80 reforms are looking to strengthen their core mandate in humanitarian and conflict zones, and then looking at whether they should merge some of these agencies. UNAIDS has been absolutely decimated with over a 50% staff reduction. And there's now a discussion about where should we now place HIV functions? Does it stay with UNAIDS, or does it get absorbed into WHO or other programs? UNFPA and UN Women, two different agencies, are discussing whether there could be a merger there. Humanitarian agencies are looking to see how they can work more efficiently together. And overarchingly, what has been picked up from all of these discussions is that very often we set things up like the Global Fund and Gavi, and we don't put a finishing date. So people are saying now, as we've heard from the Gates Foundation, that they want to close their books in 2045. What do we do? Do we have a finishing date? There's also a bigger emphasis on regions now, which is a change. And I'm giving the example of Africa CDC that really came into its own during the COVID outbreak. It was set up to strengthen our public health systems in the region to prevent, detect, and respond to disease threats. And it's an agency of the African Union with a statute and a budget. And really it is there to look at epidemic intelligence and in emergency responses. But they've taken on a very big role in vaccine procurement. Not only did they do it for COVID, but they're doing it now for Mpox. But they are partnering very strongly other institutions in the region. And attached to that regional is, from the African Union, a request that we actually refocus on vaccine manufacture. The ambition for the African Union, and through the Africa CDC, is that we should be manufacturing in this region 60% of our vaccines by 2040. Remember the figure I gave you? Only 1% now. It's hugely ambitious. 22 diseases, vaccines for 22 diseases have been identified. And people are talking about whether we just do fill and finish, but there's now a demand that actually we do the basic research. And Shabir has been very involved with this, with the BioHub, to say we should be doing the basic research that develops new vaccines, not just doing the fill and finish where you just fill things. Attached to this, and you've seen the disaster that we've had with the reduction of funding, people are looking at new ways of financing health service and new ways of financing research. So for funding global health, both services and research, here are some ideas that are very seriously out there now. Domestic resource mobilization. You've all heard health ministers say, well, okay, PEPFAR's gone, but actually we do need to take more responsibility. We need to look at this. We need to say what percentage of our national budget goes to health. So how do we fund that? And there's a discussion about smart taxation, things like sugar and tobacco. Diaspora remittances are very, very important in many countries. Can you dedicate them to health? And then innovative finance mechanisms. You saw the debt that many countries are in. Can we negotiate that debt, instead of being paid back to the institution that lent it, such as the World Bank, that is actually directed to global health, to local health spending? And then levies on things like airline tickets or financial transactions, which can be very small, but which mount up. There's a big thought about what's called blended finance, where you combine public funds, philanthropic funds, and private investment. Many of us in the public sector used to really steer away from private investment, but that's coming in. And the solidarity and the philanthropic models are still there. The Gates Foundation, the Wellcome Trust, they're still there. And ODA has not been cut off from countries. There is still going to be development aid funding coming through. And then specific things, as I've mentioned, the pandemic fund, specific funds that are funded for a specific reasons. A social impact bond. This is where you give a bond to a project and you say, you don't have to pay that back if you get certain outcomes. And this has been done successfully by the MRC recently. And then regional pooled financing, and this is very important, thinking about pooled procurement. If you get a lot of African countries to work together to buy, say, a vaccine, you can beat the prices down because of volume guarantees. And then there are innovations such as volume and procurement guarantees and what's called advanced market commitments. And there are organizations such as MedAccess and Gavi that are doing this, and this guarantees a marketplace for the private sector. And then finally, thinking about research and emerging technologies. And here is a bit of a shakedown. I haven't shown you all the data, but lots and lots and lots of studies that have shown that Southern-led research is still way behind. That in fact, the research papers that you see that are published, really excellent papers, very often will have a first author, majority authors, or who are from high-income countries. And in one study, 1 out of 7 papers for countries in the African region had not even one author from that African country. So this is a recent paper that's really re-looking, and it's come from the World Health Organization's think tank, on how do we do global health research going forward where we have equity. Research, and particularly clinical research, has concentrated in high-income countries, and it's just been disconnected in many cases, not completely, but in many cases from the needs of the low middle-income countries. So here are some thoughts about what we should be doing. We should have stronger funded national research ecosystems. And well done to the MRC, well done to WITS for bailing out the researchers in this current crisis. This would mean that instead of being given an agenda from outside, that we would have national and regional priorities, that we would integrate our research with health systems, which would allow rapid uptake that we're seeing, for example, at the moment with the new HIV prevention drug, lenacapavir. That we should focus on leapfrogging technologies and interventions, that we don't have to do everything from the letter A. We should have research that can pivot quickly to emergency research when needed, and we were able to do that because of our HIV background with COVID. Strengthen local, global, and southern research leadership, and strengthen regulatory and ethics oversight. And this is another win that we've seen, that the national regulatory authorities, particularly in the African region and low middle income countries, with the support of the World Health Organization, because of the priority that we saw during pandemics and outbreaks, are being strengthened now. They are absolutely essential to approve safe medicines, to approve effective medicines, clinical trials, manufacturing. If we don't have effective regulators, we can't do this. And so there's now a global benchmarking exercise going on for these regulatory authorities. And we are establishing an African Medicines Agency, a bit like the European Medicines Agency, which is going to support regulatory harmonization in the region. And then leapfrogging in terms of research. I think AI is just so important. And I've just given some examples here so that you get a sense of what that leapfrogging could mean. For disease surveillance and early warning, we could use AI for predictive analytics for outbreak detection. For diagnostics and care, we could use AI imaging for TB, malaria, cancers. For drug and vaccine innovation, this is already happening. We can use AI to develop new vaccine antigens and new therapeutic molecules. For health systems and equity, AI could be used for supply chain optimization. Very often the reason people can't get vaccines is because of stockouts. Personalized and precision medicine should not be seen as a high-income country only facility. We should be looking at studies that look at affordable genomics and precision medicine. For medical education and the workforce, we can have AI tutors for community health workers. And for climate and health, and this is already happening, we can link climate data with health outcomes. And just one study that shows you, and one technology that shows you how effective this can be. In the low and middle income countries, particularly in the African region, many women, 300,000 women die every year with maternal deaths, and 2 million babies are born stillborn, and about 50% of those women never have an ultrasound, which could be the difference between survival. This is just one example of the kind of technologies we could be looking at in terms of leapfrogging. It's called Baby Checker. It's a handheld ultrasound. The user can be trained to use it in just 3 minutes, and they can get a result on an app on their phone telling them whether this is a risk or there's a problem or not with the pregnancy, and then they can refer. And the initial outcomes in this region from countries like Sierra Leone and Kenya are very hopeful. So finally, just a thought on scientific integrity. People are getting very worried about the questioning of scientists, and now I'm saying to us all in here, scientists, clinicians, civil society, we must all become vocal advocates in support of science and evidence. And this is from the elders. Even the elders have picked up on this, and this was Gro Harlem Brundtland, who's one of the elders, who had a webinar looking at why leaders must uphold scientific integrity over what she described as political opportunism. She said the fight against disinformation is a fight for global health, especially as we continue to rely on vaccines to protect lives and prevent future pandemics. So she said this, and this study from Heidi Larson at the London School looked across many countries, and we sit there and said, how do you get people to trust in science once more? Who should lead the messaging? And if you look at the right, it says scientists in orange are not number one to lead the messaging. In fact, family is number one. Scientists come up there, but family and friends are really important, as are community and religious leaders. But in her study that she did here, she talked about the need to think again about activism and rethink our strategies for activism. That there couldn't be, there's not only one style of activism, there's not only one side of us making our points, but we should think about how we work with the status quo, challenge the status quo, or against the status quo, depending on what the issue is and who we are. And finally, I'm going to leave you with this very good quote from a very dear friend who I worked with on the Gavi board, Dr. Nkosi Okonjo-Iweala. She's now the DG of the World Trade Organization. And she said, some traditional donors have lost faith in the conviction that underpinned aid. The notion that our future prosperity and their future prosperity would go hand in hand. While this is still true, their populations are no longer convinced. The world as we know it has changed for aid, trade, and development. We are not likely to return to the familiar status quo. These shifts present Africa with obvious challenges, but they also contain opportunities for the continent to move forward and deliver better. And I'd like to thank everyone here. I'd like to thank the Adler Museum colleagues very much for this invitation to give this talk. David Curry, who I brainstormed and gave me all sorts of ideas for this talk. My colleagues Sidi and others in the WHO Afro and WHO headquarters, and all my colleagues at WITS RHI, and the many citizens who have participated in the many studies I've mentioned here. But I think all of us would want to offer support and solidarity to the many colleagues, friends, and citizens in institutions and communities who are still being affected by recent global events. Thank you very much.
Thank you very much, Prof. Rees, for that enlightening talk. Yeah, just the amount of insight and wisdom is really astounding. So for the next 10 minutes, we have the privilege and the pleasure to welcome Precious Matsotso to comment on Professor Rees's lecture. Before you come up, I want to read your bio quickly. So Precious is the former Director General of the South African National Department of Health, and currently is the Director of the Health Regulatory Science Platform, a WITS Health Consortium division, and previously an honorary lecturer in the WITS Department of Pharmacy and Pharmacology. She also is an adjunct professor at Sunway University in Malaysia. Precious co-chaired the successful World Health Organization intergovernmental negotiation body that Prof. Rees had referred to, that successfully culminated in the development of a legal instrument and international convention. Precious also has served on various advisory bodies, both nationally and internationally, over her career. She was the head of the South African Medicine Regulatory Authority and was the WHO Director of Public Health Innovation and Intellectual Property. She chaired the WHO Executive Board as well as the Health Emergency Programme Independent Oversight and Advisory Committee. She served as a member of the UN High-Level Panel on Access to Health Technologies, and she is a member of the Lancet Global Health Commission on High Quality Health Systems. She was the co-chair of the WHO Digital Health Advisory Group. Precious has received numerous significant awards for her contributions to public health, most recently the SAMRC President's Lifetime Achievement Award for her dedication to health systems and equity. So clearly somebody who has a huge impact on policy and is very, very well networked and connected. Welcome.
Good evening. I was quite pleased to be invited to give a commentary tonight. I would like to say all protocol observed, and I'm told by diplomats that people who say all protocol observed are lazy people. I'm pleased because it is Wits University and the Wits Health Consortium actually that gave me this opportunity to lead the negotiations for the pandemic treaty. And it has been unprecedented that, as Helen said earlier, that we had the international health regulations that was just amended a year ago. Whilst that was happening, we also had negotiations for the pandemic treaty, which is now called the Pandemic Agreement. It has never happened globally. And these are the shifting sands that you refer to, that you have two legal instruments negotiated at the same time. One, an already existing instrument that was created in 1951, but of course, subjected to several amendments. The other instrument, which is the Pandemic Agreement, was drafted from scratch. And I would like to reflect on that briefly because those who are lawyers, I guess they are in this room, will know that in treaty making, you actually get the best legal minds to sit around the table and produce a legal draft for you. But with this pandemic agreement, what was different is that everything that Helen said earlier was what influenced the content of the pandemic treaty. In that, there were a number of evaluations that were conducted during COVID. There were a number of reviews that were conducted. So we collected all of those and tried to understand what is it that this treaty will solve? What is it that will be different when this pandemic agreement is adopted and agreed to? And it was clear that some member states were of the view that actually you don't need a pandemic treaty because you already have international health regulation, and it's an instrument that has been used and applied and implemented for years. But then the question arose as to if we did have the international health regulations, why could we not stop COVID? And why did we fail? We failed as nations, we failed as a global health community. And it's understandable because if you look at the WHO Constitution, there are actually provisions that allow for pandemic treaties, conventions, to be created. But there are also provisions that allow for regulation. So I think at the time, those who created these laws, historically, because Helen has shown you the journey, the outbreaks, and when they first came up with the international health regulations, that it was an understanding that these are hierarchical in that there is hierarchy in the manner in which these legal instruments were created. The first being conventions. You are all familiar with the Framework Convention on Tobacco Control, which we adopted as a country and we're implementing. So this will be the second time that we have a legal instrument of a similar or equal status. But that is different from a regulation. As you know, the regulation is only limited, and Helen has already explained that the international health regulations assume a certain status. So the major difference between the two is that with IHR, for some countries, you don't have to go to parliament. You don't need that kind of ratification. The international health regulations can be implemented without any form of ratification, whilst any convention, any treaty, any legal instrument of that nature and an agreement would require Parliament to ratify. But in essence, what it means is that there must be appropriated funds to ensure that implementation can happen. So with that background, I just want to quickly give you an overview, if you agree, of why this treaty. It's clear that what happened with COVID, but in particular, inequitable access is what drove most of the member states to say, it is not enough to have IHR. We need something that will correct these shortcomings that we saw with COVID, where we had inequitable access, particularly in Africa, as Helen said. And for that reason, we started the drafting process, and I co-chaired. But what is significant is that with the shifting sense, Helen, that you referred to, the very first day that we started the negotiations is when Ukraine was hit. So for the day, the discussions were about Ukraine, not about the pandemic treaty. So if you look at the treaty, the content has also been essentially influenced by what has been globally happening. But as we're negotiating also, the Gaza happened. And if you look at the content of the pandemic treaty, you'll realize that the negotiations are not just about the technical issues only, but they're also about the geopolitical environment and the developments globally. So there's a group of countries that have been subjected to sanctions. And I thought I would refer to that because I'll talk to perhaps who've somehow referred to most of the things. So I'm basically filling some of these gaps. I'm referring to these countries because you know that there are countries that are subjected to sanctions. And why is it important? It's because during COVID, during outbreaks, it cannot be that countries can be subjected to sanctions, because if they cannot deal with those outbreaks, if they cannot respond adequately, it means they'll not be able to control the spread, and we will fail in our duty to address these. So it was for the first time that I heard sanctions were called unilateral coercive measures. It sounds very, very nice wording. Of course, in the diplomatic field, they've got all these terms. But what these groups of countries did, they said during COVID, much as they found other ways of accessing supplies, but the suppliers did not want to make these medical supplies available. And it is for that reason that they wanted this pandemic agreement to deal with this particular issue. But of course, they introduce wording, language that refers to unhindered access, meaning access must be ensured during pandemics. We normally talk about equitable access, but here we were seeing now a new term introduced that dealt with equitable access. And it is for that reason that when we look at this pandemic agreement, we should also take into account all these developments that are taking place across the world. It is not just about infectious diseases only, it is also about climate change, as Helen said, but it is also about conflicts. There are countries that are in continuous and chronic emergency situations. They do not come out of those situations. And if there are any outbreaks, if there are any pandemics, these are the countries that also require attention, because our failure to respond in those settings means we will never be on top of some of these outbreaks. So as we negotiated this agreement, we recognize that, firstly, as Helen said, One Health approach is important because of the zoonotic spillovers. We know the link between animal health, human health, and environmental health. But of course, in the nature of negotiations, there's always lack of trust, and this lack of trust is probably what we have to deal with, not only in South Africa, but elsewhere in the world. The African region, supported by other developing countries, were of the view that One Health is actually an agenda of Europe. But if you reflect back and you look back at when we had the Ebola outbreak, you'll realize that it is actually the ministers of health in West Africa that pronounced that, based on what we experienced with Ebola, we'll follow a One Health approach. So if anything, it should have been the African region that pronounced first that this instrument had to be based on a One Health approach. But it is also within the African region that said pathogen access and benefit sharing is important, and that we must keep this as an important principle and a heartbeat of the pandemic agreement. And as the negotiations were going on, we could not agree on the content, but of particular importance, there was an understanding that perhaps, because this is such an important issue for researchers, an important issue for industry, but an important issue for science, we needed to give it time so that there must be further work. It is for that reason that when the pandemic agreement was adopted, we still had the pathogen and access and benefit sharing as an annex and as further work to be developed. Others have said the pandemic agreement, Helen, is a historic, legally binding instrument. One would have understood that, given what happened with COVID and what countries experienced, that they would all vote in support. But on the eve, I think about an hour to adoption of this treaty, one country decided that they wanted a vote. And the model of work of the UN, the multilateral system, is that they like working based on consensus. They don't like voting. It sends a very negative signal. But I think for a pandemic agreement and for what people had experienced, it was odd to have a country say, let's vote. And we want to vote no. And others said, okay, bring it on. Let's vote. And 124 countries voted yes for this pandemic agreement, which has a resounding support for this agreement. 11 countries abstained, and not a single country voted no. And for those who abstained, they said, well, they are abstaining because they've got legal processes, they have to first get mandates and parliament and so on. But the fact of the matter is, we have a pandemic agreement that is agreed to. But it is only the beginning of this work. The work begins because we still have a pathogen access and benefit sharing, which must still be negotiated. But why do we need pathogen access and benefit sharing? As you said, Helen, it's because we need these pathogens to be shared timely. The biological materials must be shared as quick as possible. But because of this distrust, mistrust, others think that they've been treated badly in the past. They would share pathogens, but they would not benefit. They would not get supplies. They would not get vaccines. So now this legal instruments is meant to remedy that. And we're hoping that the content, in terms of the methodologies, the terms and conditions, would be such that it will satisfy the requirements that we had set ourselves and ensure that there's equity, and in future we'll not have problems with equitable access. But that is not all. Of significance is that we all experienced the crisis, the financial crisis, but there is hope. Hope in that we are saying in this pandemic agreement, there must be coordinating financing mechanism, because frankly, there is a lot of wastage. Multiple funding arrangement, flows of funds create also some inefficiencies. So if we can create and use this as an opportunity to create coordinating financing mechanism, I think it creates an opportunity also for those who want to fund, because they see this as a way to bring about efficiencies, because there are clearly concerns. We're hoping that with the creation of the Conference of Parties, which is supposed, the work begins now, that all these measures to have the coordinating mechanism, it will deal with what we've just experienced, because it cannot be that the world relies on one country, because this is what has happened. We have all sat back and allowed the US to fund and thought it was okay. So with this creation of the governance arrangements for the pandemic agreement, which actually is also intended to serve the work on the international health regulations implementation and its amendments, we are hoping that it will help provide support not only for the implementation of the pandemic agreement, but also to create a proper global health architecture. But it's true, WHO needs to be trimmed down somehow, because others have argued that there's a lot of fat, and indeed it's not only WHO but other agencies. But as to how you trim, what you trim, is going to be extremely important. I'll stop there. Thank you.